All right, good afternoon, everyone. Welcome. I'm really excited to introduce Dr. Sarah Wiehe, who I think many of you know. Dr. Wiehe is a board member of the Regenstrief Institute. She's also a co-director of the CTSI. She's Associate Dean for Community and Translational Research. She's a professor of pediatrics and has a long history of working with data. She's very familiar with the data, has worked for many years with the Regenstrief Institute and Regenstrief Data Services. She's a pediatrician and public health researcher, so a lot of her research has touched on, I think, some of the topics that we're going to hear about today. So really excited to hear from her today, and thank you so much for being here.
Thanks, Rachel. I hate public speaking, but it's a friendly audience and many friends in the audience. So, okay. This is the official title, I think, but maybe a subtitle that wouldn't fit on this slide, but I wanted to talk about to kick us off was that this is really a use case for what we hope to build, social health information exchange here in Indiana. So I just wanted to start by asking folks in the audience who does not know what a social health information exchange is. Okay, so I see some hands, so I just don't want to be covering things that are maybe already old hat, but I'm sure many of you do, so bear with me. So a social health information exchange is a technology-driven framework that enables the secure electronic sharing of data between healthcare providers and social services organizations. So it bridges that gap between medical care and social drivers of health, such as housing, food, and transportation, to improve care coordination, reduce costs, and support whole person care. It has many of the similarities as a health information exchange, but expands the type of data being shared and the participants involved to include community-based organizations, behavioral health providers, public health entities, and insurers. And as you know already, IHI has many exceptions in several of these cases. But to my knowledge, there is not a true social health information exchange just yet here in Indiana, but hopefully soon to come. So core components of a successful social health information exchange is, of course, the technical infrastructure and interoperability, but probably even harder, as many of us know, is the governance and strategic planning, the data sharing and privacy protocols, including consent, management in a community setting, which can be incredibly challenging, as well as the partnerships and stakeholder engagement and sustainability. So easy peasy. That's what we were hoping to tackle with this project. So I want to start by acknowledging the fact that this work represents a collaboration among many longstanding and trusted partners. The engagement and perspectives of these partners have enriched the work and contribute to its sustainability. And the composition of our partnership network we'll talk about briefly in a few slides, but I wanted to highlight in particular the Indiana Health Information Exchange, who has been really central to this initiative and similar ones over the last 10 years or so. And we're especially appreciative of the data sharing partnerships, who are also in our stakeholder partnership group. That includes the Indiana Family and Social Services Administration that have provided Indiana Medicaid data, and Regenstrief Institute, of course, who provided the Indiana Network for Patient Care data. And then these data were linked with the HMIS data from CHIP, who is and that's the foundation of our analyses that we're presenting. The project was supported by Indiana University Health and the Riley Children's Foundation and the Jean and Jerry Bepko Chair Endowment Fund. And a big thank you to our respective research teams, including from CHIP, Sam Clark and Abe Roll, and then from the CTSI / School of Medicine, Elaine Cuevas, Sammy Garby, Ryan Healy, Tammy McCaskill, and Unai Miguel Andres. Could not be done without them. And I wanted to give a special call out to Dr. Chelsea Herring-Cozy, who is the co-PI and co-lead on this initiative with me. Chelsea, as many of you may know, is a champion of collective impact, a compassionate leader, and an advocate for equitable and effective systems change. She serves as the CEO for the Coalition for Homelessness Intervention and Prevention, or CHIP, which is the lead agency for the Indiana Continuum of Care and the Streets to Home Indy initiative. And Chelsea and I have partnered for, gosh, almost a decade now, and I've learned so much from her. She and I co-presented much of this content last week at the MPH Data Day, and I've adapted it a bit for this presentation today, but unfortunately Chelsea wasn't able to join today. But and that's unfortunate for all of you because she does such a good job at complementing my sort of data geek focus to the presentation, but I'll do my best. Okay, so this is a quick agenda, which I'll try and fly through so we have some time for questions. So I wanted to begin with framing today's discussion and this project at large by grounding the conversation in shared values before systems and data. By emphasizing seeing and bearing witness and creating systems, these words capture the progression from the human experience to policy and practice, acknowledging that homelessness and poor health are not isolated failures, but rather outcomes of how systems are designed and connected. So this quote creates a unifying lens across these sectors, being healthcare, housing, and policy, to be positioned not as separate responsibilities, but as collective obligations to respond to the vulnerability with coordination and intention. So let's think beyond individual programs or data sets and think about cross-system solutions with data on our minds, but humans on our hearts. So I wanted to start by asking some questions, but this project is really about enabling real-time data exchange to facilitate decision-making. And that's decision-making that's happening in the community and/or decision-making that's happening in a clinical setting. So these questions are really framed in that context and not as a researcher per se, although the linked data do have a lot of implications for researchers, which I'm very excited about. We can talk about in the Q&A if you'd like. So who here has worked with someone you knew was interacting with another non-clinical system? It could have been the housing system, but it could have been any of these other social drivers of health systems, but that you couldn't see the data as part of your work, either as a clinician or a community service provider. For me, this happens every Friday afternoon when I'm in clinic, every Friday afternoon, which is the only time I'm in clinic, unfortunately. But as a pediatrician, I would say almost every visit, I mean, this is within the Ashkenazi system, which seeks to serve this population or population that has disproportionate issues in this area, but it's very important from my perspective as a clinician. And how many of you think that a better data connection could have changed the outcome? Yay! Yay. Okay, so hopefully you all already understand the value proposition, but I'm going to try and go through some of that in the next few slides. So, but I want you to be thinking about what decisions would change if housing and healthcare data revealed a more holistic journey of the person. So that's what keeps us going. It's our why. So we're starting with the person, not the data set, and specifically, let's just think about, for those of you who are not clinicians or haven't had this experience before, that someone experiencing homelessness visits an emergency department and then a shelter and then a community clinic all in the same week. This is not that uncommon. Each system sees only a fragment of their story and no one sees the full picture, so no one can fully help. So in my opinion, we can do better, and we can do better with these linked data. So we're talking about how can we link these data across systems, not so much about just the technology, but whether that person is seen, supported, and spared from falling through the cracks again. So said in yet a different way, what if we could see the whole person, the whole picture of a person's need, not just their housing needs, but their healthcare needs as well. A lot of our use case that we'll be focused on today will be in that community setting, because it is one of the most challenging from a data exchange standpoint. So this information and the whole picture can help us with choosing the path that will get a person to a stable place more quickly and more effectively and less costly, by offering effective and efficient resources to people with the highest needs and vulnerabilities. and including care coordination across fragmented systems, reducing barriers, and allowing for tailored interventions. And this would ultimately lead to a more proactive person-centered solution at a systems level to promote stability, dignity, and long-term well-being among individuals seeking those services. So this is a brief background slide. There are, I think, several people in the audience who have been along this journey with me and committed to this work for now almost a decade. It's been a labor of love, and with each iteration, we've learned more and more and remain committed to advancing this work. Someday it will happen. Some of what we've learned through our journey is reaffirmed by our learning with exemplar communities, and that's part of what I'm gonna share today. So for those of you involved with the Monon Collaborative, a couple of years ago, this is a flashback for those. I don't mean to go through this whole slide. It was just more brought a smile to my face looking back through my old slide decks and files. And this is what we affectionately referred to as the layer cake, developed by Troy Heggie and several partners back then, about 5 years ago, 5 or 6 years ago. And for the purposes of our current initiative, we have a very simplified version. One of the things we learned in that process was that you can't boil the ocean, right? This is hard work. So we got to start in a very focused way. So where we're focused in this specific project is in that red bolded line between iHigh and CHIP. But I'm going to be making the case across the different use cases for how real-time data exchange would influence outcomes. So these linked data could be shared back to the clinical point of care. As we know, oftentimes it is not clear, even for people who are in an inpatient setting, that a person is being discharged to an unstable housing situation until sometimes 24 or 48 hours prior to discharge when they're starting to request that type of information. But what we've heard both from clinicians as well as from homeless shelter providers is that oftentimes this is trying to be coordinated at the last minute, and often in a situation where at least the housing provider doesn't feel comfortable accepting a patient because of the wound care dressings or the responsibilities requested of them in a perhaps not ideal situation for that type of care. So knowing earlier, offering more wraparound services and better coordination of care during that discharge process and getting stable housing options or something that would be safe for that person to be discharged to could help with their clinical outcomes and also costs and not delaying the timing of discharge. So I think hospital systems, healthcare systems have seen this quite a bit and are quite motivated by this. And that is very meaningful from a sustainability standpoint, of course, because this all takes money and effort to sustain. But the use case that I'm going to focus on today is really the one in the community. And it may be one that this audience is less familiar with unless you've had interactions with the with homelessness services yourself or from your contacts. So what oftentimes happens when a person presents for housing services out in the community, like at a shelter, for example, there is not adequate, there's not sufficient services for the number of people that are seeking services. So they need to be triaged. And certain programs have certain characteristics that they use to make that decision. A big one is with clinical conditions. Currently, what's happening is that many of those clinical conditions are initially being asked of the person presenting for care. Do you have schizophrenia? Do you have a do you have an opioid use disorder? Do you have a chronic condition X, Y, and Z? And then if they say yes, then they are calling different health systems and trying to verify that information in order to complete the needed paperwork to get them in the door with the housing service. It's very time consuming. There's limited resources. So as you can imagine, this is not efficient nor effective manner to triage those services. And so that's largely what's driving this use case from the community perspective. So these were the aims of our project. We are not going to talk about AIM-1, but this is one where Sean Granis and others have been intimately involved. Thank you, Sean. And to Sammy Garvey, who on our team has led this aspect. But as you imagine, we're well positioned with all of the expertise of the Regenstrief Institute to tackle this, as well as with IHI, who does this day in and day out for clinical data. But we were trying to extend that to sort of this new data source, which is HMIS, that houses the homelessness services. What I am going to talk about are the AIM-2 and AIM-3, but in reverse order, starting with the engagement AIM-3, and then investigating healthcare utilization patterns among people experiencing homelessness. And specifically what we were looking at here, or what we hypothesized, was that individuals without Medicaid enrollment at the time of presentation to a homeless shelter would experience more acute care needs, for example, in an ED and inpatient setting, perhaps because of that lack of coverage. And that was sort of the value proposition that we were going to be using with the state and others to hopefully get to the next step from a cost benefit standpoint. Okay, so we've sought to engage with partners to address the legal and governance challenges and to potentially establish a real-time social health information exchange. Again, this was a continuation of some earlier work. This represents some of the thought leaders and project partners. It does not include those that are part of the IU/CTSI team, nor the members of CHIP. So as you can see, it's a varied group, a lot of really invested folks that brought important insights and actually additional use cases to our work that I won't talk about now, but I think are also very interesting and could help to sustain the work. This group worked through sort of what their hopes and fears were, as well as challenges. As you might expect, the top challenges was not sort of the technical complexity, but rather the data privacy and legal barriers, as well as sustainability and funding, not surprisingly. And then we organized our thoughts and local experiences to guide our priorities and our engagement with exemplar communities across the country. So really tried to identify what key questions did we want to learn from others that perhaps were ahead of us on this journey, so that we could perhaps steal some of those ideas and apply them to our own context here in Indiana. So we conducted these interviews with several exemplar institutions, which I'll highlight on the next slide. And then we shared meeting summaries and recordings. Many of our stakeholder group attended actually all of these meetings, and we shared sort of the opportunity to ask questions during each session. These are our exemplars and when they happened and who we talked to. So it included 6 different entities across the country, as well as folks here in Indiana, to share their amazing and longstanding work to support collaborative and data-driven decision-making and policy formulation, all with the goal of learning and applying these learnings to our efforts to create a real-time social health information exchange. So I was going to highlight just 2 of these and as some of the things that we've learned along the way. So this is the Michigan exemplar. So in Michigan, they are linking Medicaid and HMIS data. I'll note, I should have noted this earlier, perhaps HMIS data is the data repository for basically any kind of housing services that are accessed, and it's a national common data model. Can you believe that? A national common data model. So what does that mean? That means that if we can figure this out in Marion County with our CHIP partner, we can scale it statewide very easily. And the reason is because CHIP, which is basically the honest data broker of the HMIS data here in Marion County, IHCDA is for the balance of state. So with 2 community partners, these data can be accessed and linked in the same exact format. And this is also the case in all the other states across the US. So we can learn from Michigan, not just in terms of how they addressed this, generally, but how they addressed this very specifically, which was a bonus. And a big reason why we started with housing as our use case for a social health information exchange. So in their case, they link Medicaid data and HMIS data. One of the big challenges, of course, is making health data available to a community agency because they're not considered a covered entity. So it violates HIPAA regulations. Their way of addressing this was by creating a homeless vulnerability score using the health data. So they synthesize those data based on the criteria that are used to make housing decisions, to make like whether or not a person qualifies for a particular housing, opportunity, and they put them on the scale. So nothing specific and granular is shared with Wheeler Mission, for example, on a particular patient. They're able to just see that John Smith has a high, medium, or low, vulnerability scale. And then they can go on to get consent and additional permissions to access the data in a way that, can help to expedite their enrollment process. This is brilliant. In my opinion, and a big leap over some of the big regulatory and legal barriers to access of clinical data in a community setting. So hooray. And another exemplar that I wanted to highlight was Georgia's, actually the last group. Maybe some of you in the room who came from Georgia are more aware of their system than I am, but they have just recently combined several health information exchanges in that state into a single statewide health information exchange. And so we were very interested in learning from them as like potentially something similar to what we have here in Indiana. And they have what they call Georgia Unify, which is sort of on that clinical side, which helps to manage all the social services data, if you will, across these different sectors, which is very exciting. And they have this access to not just professional agencies out in the community, like community organizations and schools and so on, but also individual access. As an individual, you can log in and see your own data. So that's very cool, like across the entire state for all these systems. It's quite remarkable. The challenge is that they have not. So these data from Georgia Unify are fed into their health information exchange and then available to both providers and payers. It does not go the other way around. So Georgia and Michigan need to talk to each other. Anyway, I think they're working on that piece, but I think that's a place where we can learn from Georgia and learn from Michigan to potentially do some sort of hybrid here, which I think gives me hope that this is in fact possible. Okay, so these are some of the recurring themes of what we learned, and many of these are probably not surprising, but I'll just cut to the chase in terms of the bottom line. Start narrow, build trust, share strategically, improve value, and then scale. That's exactly what we're trying to do. So great. All right, so incorporating the lessons learned, I come back to the use cases and just sort of outline that we're hoping to sort of explore the possibility of some sort of risk score based on utilization or disease phenotypes and Medicaid enrollment patterns. Maybe not, we'll see. Lots of discussions yet to happen to work through those details, but I'm excited about a very strong foundation that we've built and some very tangible paths forward that I think are viable. Okay, so then I'm going to talk about the data part of it, aim 2, which was to investigate healthcare utilization patterns among people experiencing homelessness. So this was using those linked data of Medicaid, IPC, and HMIS to look at this. But first, I want to take a quick second to share that a housing service is not a housing service is not a housing service. It's similar in clinical settings, right? But this is something maybe that I at least wasn't like aware of until I was really delving into this in much more detail with these analyses. So there's a lot of different housing services available in Indianapolis. These are just 4 of them. These are 4 of the more intensive ones that we sort of pulled out to look at specifically. So permanent supportive housing, you may have heard about because it's been in the news a ton. It's long-term subsidized housing paired with ongoing supportive services for people with complex needs, such as chronic homelessness, disabilities, or serious health conditions. Housing is not limited and does not require participation in services to remain housed. This is a housing, it is permanent, theoretically. They will not kick you out. It will continue on and on and on as long as they have funding, which is, I guess, an asterisk there, but it is not intended to stop. It's not a temporary until you get into another program or another thing. No, it's like you start and you continue indefinitely. Rapid rehousing is short to medium term housing assistance combined with light supportive services to help people quickly exit homelessness and stabilize in permanent housing. And the focus is on reducing the length of homelessness and transitioning households to self-sufficiency. So this is a very different model, right? So that's why we don't lump everything together. Other permanent housing is permanent housing options that provide long-term stability without intensive services, such as housing vouchers, public housing, or unsubsidized private housing. And these programs are designed for households who can maintain housing with minimal or ongoing support. And then transitional housing is time-limited housing paired with structured support services intended to keep people prepared for permanent housing, and stays typically last several months to up to 2 years and often include goals related to employment, health, or stability. So not staying on supported housing long-term. Okay, so who seeks housing services in Indianapolis? This is among those 4 programs. And as you can see, there is no like that archetypic person that or persona that you may be sort of thinking about as that person experiencing homelessness is not one thing, right? It spans the lifespan across race, ethnicity, across sex and gender, and across housing type. I was frankly surprised that a third were in households with children. And that so many are minors in these programs. So anyway, this is what I see as a pediatrician, right? Okay, and then as I mentioned, sort of by definition, how long a person stays in housing is variable, both within and across programs. And in part, that's because of the time window that we're looking at, you know, where there could be both left and right censoring. Okay, so why study healthcare utilization and housing services in Indianapolis? Well, depending on who you ask, the answer to this question could be different. But from my perspective, this is a part of it, an important part of it, which is that these are individuals who, you know, 20 to 38% have a mental health diagnosis in the 2 years prior to program entry. These are folks, you know, 10 to 20% have a substance use disorder. And the Charleston Comorbidity Index is an indicator of chronic disease or chronic illness is quite high. Is quite high in this population. For those of you who are not familiar with the Charleston Comorbidity Index, a score of 5 or more, which in this case is like more than 10% of the permanent supportive housing population, have an 85 to 100% mortality rate within 1 year. Very high risk. These are people on dialysis, with AIDS, with metastatic cancer. So this is a sick population and are experiencing, you know, very stressful situations where they're having to balance, you know, having a roof over their head versus seeking clinical care. So a lot of barriers. So how do we study this question? Well, as I mentioned over and over again, strong partnerships are really key. They're key to asking the right questions, and of course, also in terms of sharing the data, interpreting the data, and making sure that we can do something about it. The rich data sources, I don't need to expound upon with this, with this audience. I've already sort of talked a little bit about the HMIS data. For this particular analysis, we focused on 2016 to 2025. linking data across these three sources at an individual level. And then looking at healthcare utilization as our primary outcome of interest. We have plans to do a lot more. This is what I'm going to focus on in the limited time we have today. So I'm going to be sharing with you some of the analyses looking at outpatient care utilization, ED visits, and inpatient stays. We looked at different time windows. There's been some criticism about whether sort of the effect of housing interventions are sustained over time, and when the maximal benefit is really appreciated. So we looked at that and then assessed effect modification by diagnosis of various conditions in the 2 years prior to program entry. Again, we focused just on a few to start. We have many more that we have plans to look at, but to start is mental health, substance use disorder, and the Charleston Comorbidity Index. Again, because these are some of the primary characteristics used to prioritize housing allocation or, prioritization. And then we assessed mediation by Medicaid enrollment following program entry. So a person is not, there's not a stair-step approach to getting into permanent supportive housing, meaning you don't need to get into transitional housing before you get into permanent supportive housing. You can go right into permanent supportive housing. However, most people have multiple touches with various types of homelessness services in these data. So it's complicated. So what we did for the purposes of what I'm going to show you today is focus on that first touch with each program type. And then we looked at a period before program entry and a period after program entry to look at a within person change in utilization. Again, looking at different time windows. And I'm going to start by sharing some descriptive statistics and then just show a few of the regression analyses that we did. Again, in the interest of time, and happy to talk more, but I want to make sure there's time for questions in discussion. So in terms of outpatient utilization, for the purposes of descriptive statistics, I am looking at it across the different housing services. This is permanent supportive housing before, which you can see only about 40% of individuals in the 3 months before program entry had an outpatient visit, 36% and 42% in the 4 to 6 and 7 to 12 months. And then we aggregated across the 0 to 12 months, which is roughly 60%. So on the whole, for permanent supportive housing, this is less than at least what the CDC reports as what adults seek in terms of outpatient care in a 1-year period. And in the post period, as you can see, there's not a significant difference. I mean, statistically significant or clinically different. And when you look across the different program types, that association or that lack of a significant change before and after holds true. However, in ED utilization, we see a very different picture. For permanent supportive housing, ER visits was higher than US adult population, though there are decreases, and these decreases are statistically significant in ED utilization after program enrollment. In fact, every housing program demonstrated decreases, at least initially, although the rapid rehousing and transitional housing decreases were not sustained after 6 to 12 months. And in large part, that likely reflects, the type of services that they receive as part of those programs. So that wasn't surprising. And then for the inpatient stay by program type, again, for the permanent supportive housing population, inpatient care utilization prior to the program entry was at least twice that of the US population, and like ED visits decreased after program entry. Not surprising, again, because this is a sicker population that you would expect to have higher utilization. But similarly, to ED visits, there were decreases in inpatient care utilization among individuals in every housing program. Permanent supportive housing and other permanent housing have the greatest decreases, and that occur primarily in the 12 to 24 months after program entry. But even transitional housing had some changes, although they were much smaller in terms of their absolute decreases in the immediate period following program entry. So what's really fun about these data is there's so many ways that we can slice and dice it. And I've just had the best last couple of weeks doing some of this. So part of what we were looking at was, again, different program windows initially to see where we saw the greatest effect, or where and then we chose one of those windows to sort of move forward with adjusted analyses across program types. Again, I'm going to be focusing on the permanent supportive housing, given the time we have, and the focus on that program recently, just sort of politically. And then given both type of program engagement and healthcare utilization have different demographic characteristics that might confound the associations and the regression analyses. We controlled for demographics, Medicaid enrollment at the time of entry, calendar year, and health conditions in the prior 2 years before program entry. So for permanent supportive housing, outpatient visits in adjusted analyses, again, didn't show a significant change in non-stratified models, regardless of the time window. ED visits had equivalent odds of decreased utilization, regardless of the time window. I just highlight the odds ratio for the 0 to 12 months, which was an odds ratio of 0.67, highly significant. And inpatient stays only had a decreased odds of utilization in the 0 to 12 and 0 to 24 month time windows, largely likely due to power. Inpatient stays are less common than ED visits, as we would expect. And interestingly, there was a nearly statistically significant housing program effect and Medicaid enrollment interaction between housing program effect and Medicaid enrollment at the time of entry, where there was a greater reduction in inpatient utilization among those not enrolled in program entry, suggesting that the program perhaps was helpful in allowing people better connection to care, particularly among those who were not enrolled in Medicaid, and maybe being offered other wraparound services through the Medicaid covered entities or otherwise through whatever care connection they had. So again, focusing on permanent supportive housing, we stratified. This is really looking at that mediation effect of those enrolled after entry compared to those enrolled at entry and who were never enrolled. This is just first enrollment in Medicaid during sort of our study period, perhaps not ever in their lifetimes, okay? So just looking at essentially the 2 years before and the 2 years after their program entry. There were decreases in ED utilization following program entry in all categories, but greatest among those who enrolled in Medicaid after entry, suggesting that that is really what's potentially one of the drivers of that decreased utilization of ED care. And there was a decrease in inpatient utilization, only statistically significant among those who were never enrolled in Medicaid. This is, I think, one of the most interesting findings, and that is when we stratified analyses based on those with or without a mental health or substance use disorder diagnosis. I ended up lumping these together because there was so much overlap, as you might expect, between these two sets of diagnoses. But I do have them stratified by each as well. But as you can see, we didn't, as I mentioned before, we didn't have a change in the outpatient care utilization. However, overall, when you stratify based on those who have a mental health or substance use diagnosis and those who don't, you can see that outpatient care actually increases among those who don't have a substance use or mental health or substance use disorder diagnosis. They're basically going from below average outpatient care utilization to something closer to what the general US population has, whereas those with a mental health or substance use disorder diagnosis had extremely high rates of outpatient utilization, and that was coming down. And those sort of basically canceled each other out when we threw them all together. But when we teased them apart, we saw this clear effect modification. You know, it's always cool as an epidemiologist to see effect modification. Anyway, and then it was also in terms of what we saw in ER and inpatient stays, and not just in permanent supportive housing, but across housing types. So people with mental health and substance use disorder diagnoses are prioritized in permanent supportive housing, along with folks with other chronic care conditions. So even among that very, that group with high comorbidity, those with mental health and substance use disorder really were driving a lot of these changes that we were seeing in healthcare utilization after program entry. Okay. So to wrap up, individuals enrolled in housing services are both young and old, male and female, all racial and ethnic groups, and overall much sicker than the general population. Housing programs seem to decrease both ED utilization and inpatient care utilization, more so among those who are not enrolled in Medicaid at the time of program entry. And for individuals in the permanent supportive housing program, individuals with substance use disorder and mental health diagnoses have significant decreases in ED and inpatient care utilization, but those without substance use and mental health diagnoses do not. And interestingly, those with substance use disorder and mental health diagnoses have significantly decreased outpatient care utilization from nearly 100% utilization before program entry, where those without the substance use and mental health diagnoses have a significantly increased utilization of outpatient care. So there's opportunities for policy and interventions on many levels, which I'm excited to think more about and discuss with our partners. Okay, so to come back to our complete, what we hope now, data picture, as you can see, we can look at individual use cases as well as patterns across use cases or across individuals at a population level to see where things are clustered, to identify patterns, success stories, and opportunities for improvement. And so the implications, we think, for having a social health information exchange are tremendous in a good way, right? For housing service providers, we hope that this would offer efficient access to key health-related data, perhaps in an aggregated or risk indicator form like we showed from the Michigan exemplar model, to help prioritize services to those who qualify or who have greater need in a more efficient and effective way. For clinical service providers, we hope it could inform clinical care and additional wraparound services for those recently experiencing homelessness or being discharged to unstable housing conditions. For Medicaid payers, to identify individuals enrolled in Medicaid who are experiencing homelessness, to assist with care coordination and to offer outreach to those not enrolled but who might qualify. And as we showed, there's clear differences in healthcare utilization among these populations that perhaps could be done more efficiently and effectively if these data were shared real time. And then for policymakers to identify and evaluate health, homelessness, and economic outcomes for policies and resource allocation relevant to individuals experiencing homelessness. So we have more analyses to do, as always, and hopefully from this we can operationalize a real-time linkage between HMIS and IMPC/IHI and possibly other data sources, and collaboratively develop a governance and regulatory model to support a pilot study using these linked data to inform homelessness services and/or healthcare and/or MCE outreach, enrollment, and care coordination in Marion County, and then statewide. Thanks for listening. This QR code will send an email to me to partner. We're always looking for more partners, so let us know, both Chelsea and I, if you guys are interested in joining our team. Thanks. Questions?
So much, Sarah. That was great. I have a couple questions around some of the maybe opportunities for research with some of the recent policy in this space in the state of Indiana. I wondered if you might comment on that. So specifically SEA 285, that was I'm sure going into effect in July, that's caused a lot of conversation around potentially criminalizing people for camping in public spaces and the unhoused. At the same time, I think the really great public-private partnership around the Streets to Home Indie program is a really good example of a success story. Maybe a combination of those, but I think opportunities for studying research and impact, and wondered if you might want to comment on those.
Yeah, great questions. It's hard to study the effects of either without the data, for better or worse, right? So I think we have a great opportunity, even if it's not real time, through a social health information exchange to do those evaluations, some of which Chelsea and I have talked about for the Streets to Home program, and certainly I've heard about along the way in terms of her advocacy, I think largely against the criminalization, as you might expect. This particular data set doesn't capture those individuals out excuse me, it does, I think in some cases, they were not included in the analyses that I shared because these are largely, bringing folks into programs that involve, not being out in a tent or out, in the community. So in order to get at that most effectively, I think we need even better data systems, right, that could help to capture that. But I would say my sense is anyway, we absolutely need to think about trust in that context with the individuals experiencing homelessness, but also with the programs that are seeking to serve them, right? Because that may not always be there. So I think if nothing else, some of these conversations help to understand the different perspectives, the different use cases, the different value propositions that can really help fuel these types of collaborations. And then ultimately, I think, we as researchers are always very eager, to be involved and assist in whatever way we can to help with those evaluation efforts, right? So yeah, what I didn't talk about, but we spent actually quite a bit of time in the last iteration with the Mona Collaborative, was like that bottom layer of the layer cake, if you will, which is sort of the, how these data then become available for population health and other research endeavors, as well as for public health surveillance and, a variety of other things, right? Incredible value there. But we've chosen for now to focus on that real-time data exchange piece. Again, because with the limited resources available, we really need to think about efficient and effective ways to sort of make sure, people are getting the services they need and deserve. I don't know if that fully answered your question, but as best I can. Chelsea would have done a better job. Mhm.
This is from,
Is it in? I can hear you. I can repeat the question if you like. Okay, I'm just.
this is from David Hegstrom.
Hi, David.
Did you use INPC or Medicaid data or both to measure outpatient, inpatient, and emergency department utilization? If both, how did you go about reconciling data?
Great question. No, we did use both, but not for the outcome measurement in this case, although in other projects, we are looking at that reconciliation issue. For the purpose of this analysis, we only used INPC data for the utilization metric, and we only used the Medicaid data, again, for this particular project to assess enrollment history, both before and after program entry. So we didn't, but we could look at sort of the agreement among those who are continuously enrolled pretty easily. And I'll make a note to do that and circle back with you.
Thanks, Sarah.
Mhm.
A couple questions. I apologize if I missed it. Your outpatient, what kind of visits were in that? Because in the one group where it goes up, that's actually desirable, right?
Mhm.
If it's primary care and social, but did it include other things like urgent or?
Yeah. So right now, but you touch on something that's in the works, actually, this week, we're doing some follow-up analyses, but it wasn't ready for prime time. So right now, it includes anything in an outpatient setting. So it does include urgent visit. It also includes, mental health related visits. It includes, so we are pulling out sort of the visit codes as well as CPT codes to sort of identify that subset, as well as those associated with the mental health and substance use diagnosis code, just to see, how much of that was really driving. And right now, we're just looking at one or more visits, very, very blunt indicator of utilization. But certainly as we delve into more of the cost analyses and things like that, we'll be looking at both the presence as well as volume and type of encounter, as well as from an inpatient stay, not just whether or not, but how many days, et cetera.
Sure. All right, I look forward to seeing that. And then another question. Some of your, and this is my understanding, right? Obviously homelessness or housing instability is a risk for health and well-being, but I
Mhm.
understand one of the challenging sides from the healthcare delivery space is the potential placement and, for lack of a better term, eligibility of where individuals can be referred to.
Mhm.
Did any of the other states share that information back with hospitals and decision makers to help guide that decision?
Let me make sure I'm understanding before you go away, because super exciting, and I think the answer is no. But so there was information being shared back to the health systems on their homelessness services utilization. So whether they got into a, X, Y, or Z, program would be flagged and put back. However, if somebody had like services, maybe not one of these more wraparound, permanent supportive housing or equivalent, but like what we'll see with emergency sheltering, like overnight sheltering, services, which are also captured as part of these data. It could be overnight, they're never even assessed, or like if they are, not completely. So I think maybe if I'm understanding you correctly, if there was some indication that an individual was accessing emergency services for just like a one night housing stay and had not undergone the full assessment for like permanent supportive housing, but they might qualify based on what the clinician knows to be true based on the interaction, could it be sort of facilitated by the
yes.
clinical? Yeah,
Totally.
that's interesting. To my knowledge, I don't think so, but we weren't specifically asking that, so we may have missed it, but I think that's a very interesting use case, so thank you.
That would have been that would be very advanced, I would assume, so I'm surprised it didn't come up there.
Although, similar to how, we've talked about sort of the clinical risk score and prioritizing homeless services, you could have like a homelessness utilization score that indicates a lot of emergency use in the absence of like a permanent supportive housing or other permanent housing sort of being offered, as a risk score back to the clinician potentially, right? And then if that's a person that has maybe one of these other conditions or something that maybe merits more of that workup, to assess for that. Yeah, interesting. Thank you.
Hi, quick question. I saw that maybe you guys were creating this to send out for policymakers a social health information exchange. Is there any discussion around integrating like non-clinical providers that may have a hand in enrollment in Medicaid or following up and connecting to community resources, like
Yes.
even like medically or Medicaid paid doulas or
Mhm.
community
Yes.
health worker navigators?
Yes, that is actually the use case that launched the non-collaborative sort of phase, was the Medicaid covered entities largely saying like, hey, we want to know, at least at that time, and I think it's still the case, that homelessness was a Medicaid waiver qualifying characteristic. So if somebody's experiencing homelessness, if they are not enrolled in Medicaid, they're very likely to be eligible. We saw only 50% of people who were presenting to one of these, very significant programs as being enrolled in Medicaid. So likely there's, underutilization of Medicaid enrollment, right? So the folks as part of the Medicaid covered entities were very interested in basically knowing who was presenting for homelessness services that were not enrolled for Medicaid, so they could go out and offer that sort of enrollment process, and also in helping with coordination of care. That is really what was driving, because they know what we showed here, which is that if you get them enrolled and if you offer those wraparound services through doula services and other things, they're likely to see a decrease of the expensive types of utilization that they're then paying on the back end when they're getting enrolled after they're admitted to the ICU, right?
Yeah.
Yeah.
Thanks.
Yeah, thank you. Good question. Thank you. I think we're at time, but I'm happy to stick around if folks have other questions. Thanks a lot.